Hello and welcome back to Therapeutics. In this block, we have a lot of content to talk about, and yet our expectations probably don't get reflected by the number of slides here. Our expectations for you as a PA working in oncology is that you're familiar with the different treatment options that are available for patients, that you're able to identify what some of the benefits of those treatment options might be, but you're also aware of the adverse effects and toxicology associated with those regimens. As a practitioner, unless you are embedded in an oncology service, in an oncology suite, it is highly unlikely that you're ever going to be in a position to have to choose which agents patients get. But you will be expected to recognize patients at your doorstep who are having an adverse effect or an adverse outcome related to their therapy, and also work with the oncology team to support all the needs of an oncology patient. So as such, as you go through these multitude of slides with lots of detailed content, our focus and our hope for you and your focus is to really let most of this content wash over you and maybe listen to a few things that you have trouble with a couple of times if you need to. But know that in class, we will try to put this all in perspective. As a person who is providing care to patients, not an oncology service, but as a general service in the hospital, in outpatient practice, what is it that you really need to know as a clinician, we will emphasize in class. But we'll try to emphasize that as well throughout the multitude of slides here. So as you approach this, I encourage you to do a couple of things before you start. First of all, don't be overly intimidated by the volume here. Secondly, to budget your time for how much time you want to spend or you have to spend to look at this and at least try to get through all of the slide presentations once. If nothing else, just to listen to it and to absorb it and to get a sense of it so that when we're in class, we can try to uh, help you to kind of see what is critical components here. And when there's a lot of detail in the slides, again, we'll talk about, but we'll kind of try to emphasize what is the detail that as a clinician in your likely practice you'll need to be aware of. So our objectives primarily are to overview what the management states therapies are for oncologic states, how they're kind of differentiated, and also the next slide, what the major toxicities of them are. And so as a clinician, it's probably more likely you're going to see, and we see this all the time in the hospital, I see it all the time, patients who come in with toxicities related to their chemotherapy or their other regimens for cancers. And it's our role to recognize, well, is this related to the drug therapy or their intervention? What's our intermediate intervention that we need to do right away until the oncology team or the infectious disease service or whoever it is that comes in as a specialist can take over the management of that specific situation. So that's really our focus here. So let's talk a little bit about cancers in general, which really should overlap what you're hearing or will hear in clinical medicine. I think most PA curriculum, though, in a sense, don't often do cancers as their own one section, although some programs do. A lot of times, cancers instead are embedded in pulmonology, embedded in women's health, embedded in whatever the type of cancer is in that clinical medicine block. So we kind of have more difficulty in therapeutics and sort of aligning the oncology with that. But let's go through this, which you sort of, some of this already is probably content you've heard of before and others not. As we look at cancer cases and cancer deaths, we see that the number of new cancer cases continues to be high, but is in a sense almost leveling off a bit. And the projected number of cancer deaths going down only because our successful treatments, really, we have kind of made major significant improvements in cancer therapy in the last decade. They're not curative in many cases, but in some types of subsets of cancers, our 5-year survival rates are actually quite good compared to where they've been historically. So here are a number of slides here that go through some relative survival rates by cancer type that's fairly recent. And we'll see that it's often differentiated by male, female, but there's other ways to kind of break this data down. For men, prostate cancer is fairly common, and the 5-year survival rate is quite high for prostate cancer. The same is true for testicular cancer, and you can see the number of cancers listed as they go down. For women as well, we see the same kinds of scenarios, including melanomas and breast cancer, as well as thyroid cancers, with pretty good 5-year survival rates for most of these kinds of cancers. We'll go to the next slide, which depicts the types of cancers that are less responsive to chemotherapy and have a shorter 5-year survival rate. At the bottom of the list here, and probably the most dreaded of all types of cancers, are pancreatic cancers, which are, by the time they're diagnosed, usually they've already become quite invasive by their nature. We also see various types of cancers, lung esophageal cancer, stomach cancers, also with fairly poor 5-year survival rates as well. I will say, though, that as we're looking at the different therapeutic options that are available, these numbers this data sort of lags behind what some of the newer therapeutic options are, and particularly in the immunological field, there have been dramatic improvements in some of our treatment options that have improved survival. Maybe not, we wouldn't dare use the word cure, but 5-year survival rates are becoming better, and 1 and 3-year survival rates becoming better for a lot of cancers related to this immunotherapy, which we'll get to. Another way we can look at 5-year survival relates to, among other things, things that affect socioeconomic and equal delivery and access to care. And so we see this different between folks who are self-identified as white versus self-identified as black, or other scenarios, that the survival rates vary based on these variables. And so as we kind of live through 2020 and beyond, we've kind of seen the health disparities that have happened, particularly related to COVID. But these health disparities are also seen in many other conditions, including cancers. And so as such, I think important for us to continue to remember that. One of the other areas that relate to 5-year survival by race, in fact, is related to socioeconomic, that a lot of the newer treatments for cancers are very expensive. And if patients are uninsured, it may become impossible or nearly impossible for them to avail themselves of those therapies. It is not uncommon that a full course of chemotherapy for 6, 8, 12 weeks or beyond may be greater than $1 million in cost, depending on the agents. So extraordinarily expensive, for which, hopefully there are ways that these therapies can be managed in patients in an appropriate way, that also reflect the other issue we talked about in ethical issues, is what is our social justice responsibility for those resources and how they're distributed. So important for us to consider that. Here's a slide again of the what we see as the differences in survival rates by different cohorts. And again, sort of the less responsive cancers and survival rates by different cohorts. Finally, a brief slide. We won't focus a lot in pediatrics. Pediatrics oncology is its own special animal, to which I have to tell you honestly, I have no experience. And I have very little experience working except peripherally with oncology services in general for adults. But what we will see is that the 5-year survival rate for pediatric cancers has become much better in the last 20 to 30 years compared to where they were in the 1960s and 70s. Particularly relates to leukemias and lymphomas that have been much more responsive to our approaches to cancer therapy in pediatrics as well as in adults. Okay. So let's spend some time sort of framing what the principles of our cancer and cancer therapeutics are. I think it's important as a clinician to recognize that cancer isn't just one disease, but it's a group of multiple disorders. That as we see changes and improvements in infectious disease mortality, at least pre-COVID we did, cancer's really emerged as a leading cause of death. Patients over the 20th and 21st century who are living longer are more likely to have the ramifications of things that sort of impact the risk for cancer as we live longer. Our modalities include, for treatment, include surgery, radiation, and chemotherapy. And the broad groups of chemotherapy we're going to refer to are basically the two broad groups are cytotoxic chemotherapy and immunologic or biologic chemotherapy agents. A third one, which we'll briefly talk about, is hormonal agents that are triggered, certain cancers are triggered by estrogen or testosterone or something. And if we can impact the receptors where estrogen or testosterone may sort of feed a tumor, estrogen for certain subtypes of breast cancer, testosterone for certain types of prostate cancers. Then we also have some hormonal therapies that are used as well. We'll talk briefly about that in one of these sets of presentations. But we will mostly talk about the older cytotoxic agents that have lots of serious and broad adverse effect profiles, that we still use these therapies. And we'll talk much more about the immunologic or targeted biologic therapies that are evolving over the last decade or so specifically, and what their roles are. In general, at least historically, if it's a solid tumor, historically responded better to surgery and radiation, whereas disseminated cancers responded better to chemotherapy. And even with immunologic therapies, that is still generally true, but we have a number of therapies for which the older cytotoxic agents weren't particularly effective where the immunologics are. So that's sort of this sense that we primarily treat solid tumors surgically or with radiation and disseminated cancers with chemo. While that principle is generally true, it is certainly, there are many, many exceptions to that way of thinking. So as you sort of think about cancer cells, cancer's typically a simple way to think about cancer cells, and I'm certainly not an oncologist, but normal cells kind of know when to leave the party. They know when to stop dividing. Whereas cancer cells don't know when to stop dividing. And they just keep going and going and going. And so that's really when a normal cell sort of differentiates, mutates in one way, shape, or form into a cancer cell. Cancer cells just will keep growing and start to invade surrounding tissue. A sort of classic way that we think about this is that a normal cell that differentiates into a cancer cell starts to invade the particular tissue it's in, expanding beyond the basement membrane and getting disseminated into the local lymph node system and or throughout the body. And so we will look at staging of cancers and grading of cancers, in part depending on the cancer size and in part depending on their ability to invade surrounding tissue and expand beyond the individual location of the original source of the cancer. And so, of course, it makes the most sense when we think about cancers, if we identify them early, before they start to invade surrounding tissue, where they can be identified and excised early, then there is better chance for appropriate therapeutic opportunities. And so one of the dilemmas we often have, for example, with prostate cancer is, with pancreatic cancer, is that pancreatic cancer often doesn't get diagnosed until it is sort of, it's a sort of expanded beyond those boundaries where it is less responsive to intervention. So when we think of cancer development, it's a combination of your genetic history, so what you inherit from your parents, your inherited DNA, that poses some risk for what poses a risk for cancer development, but also any DNA damage that can happen after you're born. So that could be carcinogenic chemicals, that could be viruses, human papillomavirus, for example, pretty high risk there associated with DNA damage and cancer risks and the like. So all of those sort of variants that are sort of depicted here kind of can contribute to cancer development risk. We typically have tumor suppressor genes that will slow or stop cell growth, and those are really the normal cells that will turn off. But when the DNA changes lead to a cancer cell, the cancer cells sort of in a sense don't know when to leave the party, don't know when to turn off. They continue to grow and sort of spread and invade other tissue. And that really is sort of one of the common characteristics of different cancers, even though there are many different subcancer types that are triggered by and suppressed by different variables. Oncogenes are, we look at DNA changes that can occur that lead to oncogenes that then lead to this uncontrolled cell growth and survival. So you'll sometimes see that term oncogenes sort of used in the nomenclature. So as we think about our principles of how we approach cancers, we first recognize that cancers are very different. And what is going to trigger cancer and cell growth might be different triggers for different cancers. So there are many, many different targets for chemotherapy and cancer chemotherapy related to the subtype of cancer and the kind of things that will turn on or turn off the expanded cell growth in cancers. And we're going to look to target those when we can. And we sort of looked at these immunologic differences already. So what we think of classically is that the cancer neoplastic cells have persistent proliferation. They have invasive growth. They can form metastases if they go beyond the basement membrane. They don't know when to stop growing. And the etiologies we've alluded to can be related to both what you inherit genetically and changes in DNA after birth based on exposures to radiation, carcinogens, or viruses, something else. So as we look at that, we think of one of the things we think of with cancer cells is that they're rapidly dividing. And you may remember from basic biology the cell cycle, the G1, S, G2, and M phases. That's depicted here. And you might remember that most of our cells, if they're not rapidly dividing cells, are in the resting phase of G0. But when they're preparing for DNA synthesis, going through DNA synthesis, preparing for mitosis, and actually going through mitosis, those are the points where many cancer cells are in one of those states, whereas many of our other, particularly not rapidly dividing cells, are in more of a resting state. The problem with the older cytotoxic agents that we'll refer to is that those cytotoxic agents aren't very specific for the type of cell that they target, that they will really interfere with DNA synthesis or mitosis in one way, shape, or form, whether or not it's a cancer cell or a healthy cell. So the older cytotoxic agents, their toxicities are often associated with any cell that's rapidly dividing. That could be bone marrow, and the cells that produce particularly white cells and platelets. That could be GI tract lining, so mucositis is an issue. That could be the hair follicle. That could be lots of other things that affect the sort of non-specific types of rapidly growing cells that are going to be targets for the older cytotoxic agents. So important for us to have a sort of a depiction of that. This growth faction is important for us to sort of consider what sort of how the cancer is going to go, but what the relationship of the cancer chemotherapy, how effective that's going to be, but also what kind of toxicities we may expect to see. So some classic obstacles for successful chemotherapy, and these were particularly focused on when we had just the older cytotoxic agents before we had the age of the immunologic therapies. The successful chemotherapy blocks we have with the older cytotoxic agents particularly, but some of these points affect the newer immunologic therapies as well. One is the toxicity of normal cells. So particularly those high growth fraction cells that are normal, bone marrow, GI epithelial, that the toxicities, if it's non-specific, then all of those are pretty problematic. So the older cytotoxic agents often lack that selective toxicity that make them problematic. The newer immunologic agents may be much more selective there. That's great news, and that's really some of the boon we've got with the newer agents. One other area we've heard of already is the absence of true early detection. So the earlier you can detect a cancer in smaller amounts, the more effective your intervention is going to be. Partly because we don't have a lot of mutated cells going on, because the size of the tumor is small. If you do a surgical intervention, you could do that. The other issue is that solid tumors often don't respond as well to chemotherapy as other tumors do. And part of that has got to do with vasculature and how the chemotherapeutic agent can actually reach a solid tumor. So that's sometimes why we'll look at surgical or radiation interventions for solid tumors. One of the things we think about is this sort of exponential growth of tumors, and we see that the growth gets quite dramatic. And until a nodule, a cancer nodule, really has many, many, many a billion cells, it is often, a cancer loci of cancer would be undetected without some aggressive imaging kind of studies. By palpation would be undetected until you have a billion cells. Well, by the time you have a billion cells, you may already have pretty significant invasion of tissue. You may already have a lot of mutations of those cells that could become kind of like antibiotic resistance. We have cancer chemotherapy resistance happening with those mutations. And so the earlier you can diagnose, the more benefit you're likely to see. As we get on and on with the number of cells, you'll sort of see that the growth curve sort of slows down. And part of that is sort of limited by the tumor size itself. That, while the tumor cells themselves don't want to stop dividing, their access to blood supply, their access to how much room there is to even divide in that particular location becomes limited. So we really want to catch things early. We also want to be aware of the immune system in its involvement in cancers. And here are, some of the sort of basic principles we have here is that there is immunosurveillance that goes on. And this graphic sort of is a simplified way of sort of depicting the role of immunosurveillance and T cells and uh, antigen presenting cells to kind of continually survey for cancers and sort of wipe them out before they become problematic. So a patient's immune status is clearly related to their cancer development and cancer risk. And one of the things that you'll notice is that some of the drug therapies we use, the biologic therapies that we use for treating autoimmune conditions like Crohn's disease, ulcerative colitis, rheumatoid arthritis, psoriasis. Those immunologic therapies that suppress immunity may suppress the autoimmune disease itself, but they may also cause an increased risk for certain types of cancers, particularly lymphomas. Because this cancer immunity surveillance system is interrupted by the therapies we're using to manage their other conditions. And so that's always something we think of. Other things that we're thinking of here are the obstacles to successful chemo we referred to briefly already is drug resistance. That like antibiotic resistance, we have maybe resistance. The tumor has sort of changed in its way, developed, adapted, mutated. The cells in that tumor have become resistant. They developed a pathway that blunts the physiologic properties that the therapeutic intervention would cause. And we'll see this with a lot of the older cytotoxic agents, but to some degree we can see this with some of the newer immunologic therapies as well. So related to drug resistance, recognize that tumor cells aren't one cell, but if they're undergoing mutation all the time, there are subpopulations of tumor cells with different genetic markers. And so if one of those lines of genetic cells is susceptible to a therapeutic option where another line is not, well, maybe you're wiping out one line, but the other line that's not responsive to that therapy sort of can use whatever resources are available to continue to grow. And then another issues we often have is getting the drug to the site of the tumor. That may relate to blood supply or the location of the tumor or something else. And so that is sometimes a problem. So, what are some of the ways that we look to achieve sort of strategies we look to achieve a maximum benefit from our therapeutic options, whether it's the older chemo or whether it, cytotoxic chemo, or whether it's the newer immunologic therapies? One is to look at intermittent chemotherapy, particularly if the therapy, we could blast a person with that chemotherapy. It hits the rapidly dividing cells, preferentially, hopefully, and allow the rest of the body to recover before we do another blast. The benefits also are combination therapies, and so you'll often find the regimens are not just one intervention, but 2, 3, 4, sometimes 5 or more interventions that target different things. That's intended to sort of target different things that might suppress a subset of these mutant cells that might be receptive to or subject to issue with one drug where another drug would be not effective, but the second drug may benefit a different line of those cells. So we'd likely see less resistance developing. We also would see that with a different mechanism of action, some are cell cycle specific, some are not in the state of division of the cell. But we can sort of look at the different mechanisms can sort of target different cells in different ways, and also maybe reduce the toxicity that would be seen in normal cells by sort of mixing and matching regimens that make sense. So the guidelines for drug selection is continually evolving. The oncologist will typically work with a resource collaborative that will enter patients into treatment arms that will look at monitoring that patient over time to see the degree to which that patient is responding to therapy, but also put that data into and the sequencing of the regimens into a larger database so that future patients can benefit from the experience of today's patient. And so these guidelines are very specific. They're very specific for sequencing and timing and how they're dosed and lots of things that get tweaked over time. So the regimens that are used for certain cancers today might be different than the regimens that were used even 2 or 3 years ago. And they might be quite similar but not identical. So depending on how things go, we continually progress in the field of oncology to find the most effective regimens. Other things we'll look at is finding what the dosing schedule, the sequence, the route of administration. All of these are areas that make a difference. So, you may think, well, does it really matter if I give drug A on day 1 or day 2 of a regimen? Yes, it does. And there may or may not be subtle differences, but there might be differences in how they're sequenced based on the mechanism of action of the agents or how patients tolerate them or something else. And so, I'm not the expert here, but we are very, very specific about which patients are candidates for which drug combinations and which sequence at which dose and which intervals between doses that they need. We're also pretty specific about the route of administration. Most often, they're given intravenously by a dedicated line for chemo. Many of the older cytotoxic agents in particular are very caustic agents that if they were to extravasate, if they were to kind of go from a peripheral line right into tissue, would cause real significant trauma to that tissue. We are paying close attention to that. But we also may find that the drug delivery, we have other delivery options that are sometimes used, not as often as they used to be. But when we only had the older cytotoxic agents, we might look at intra-arterial delivery or intrathecal delivery or portal vein delivery, depending on where the site was, or directly instituted into the bladder for bladder cancers, or a wafer that's impregnated in the brain during brain surgery or something like that. So there are different strategies that clinicians are going to use. Finally, in this block, we're going to look at, in this mini section, is to look at what strategies we're going to use to achieve maximal therapy. We're likely to look at, for relapsing patients, to look at what a second or third line therapies are, and based on data from other patients prior to this patient enrolled in these evaluations, kind of helps determine that. The mechanism of drug resistance that happen might be genetic to that patient. It might be genetic to the tumor. It might be related to exposures. But oftentimes we find acquired drug resistance over time. And that's not different, really, from the kind of mechanisms you'd see with antibiotic drug resistance as well. And so we're continually looking for option A, option B, option C. And it's all related to what options make sense for that patient based on their type of cancer, based on their tumor markers, based on their stage and degree of their cancer, based on experience of prior patients. Okay, so that should give you a sense initially of our approaches to chemotherapy. What we'll talk in the next couple of slide decks are the cytotoxic agents. We'll talk about the toxicities of the cytotoxic agents in the third presentation. In the fourth presentation, briefly about hormonal therapies. In the fifth presentation, we'll talk about the immunologic therapies. And finally, in the sixth presentation, an overall approach that clinicians use in managing it. Again, our focus here is for you to get through this at least once, to kind of listen to it all, jot down notes or comments and questions for when we discuss things, and focus on what's critically important in class. Okay? Excellent.